Welcome to the Hospital Medicine Unplugged podcast. We are undertaking a crucial deep dive today, focusing intensely on the clinical decision-making surrounding renal replacement therapy in the inpatient setting. Our mission is to move beyond the default and synthesize the evidence that contrasts hemodialysis, or HD, with peritoneal dialysis, or PD.
And it's a needed conversation. HG has long been the reflexive choice, the established default in nearly every U.S. hospital for acute care, primarily because it's fast and familiar.
Right, the go-to.
But the unique advantages of PD, especially for the increasingly complex and unstable patient populations we encounter, say in the ICU and on the medical floors, these are often overlooked, or sometimes they're just institutionally difficult to implement.
It really sounds like an issue of culture versus capability, doesn't it?
It often is.
Our goal, therefore, is not just to compare mechanisms, but to establish the precise clinical care considerations for selecting the optimal modality for you, the hospitalized patient, based on their specific physiological state, the urgency, their underlying comorbidities. We have to identify precisely where PD doesn't just work, but where it might truly offer a superior clinical outcome in that acute setting.
And that synthesis really begins with understanding the core mechanisms, how they actually work.
Okay, let's unpack the foundational differences then, looking first at how these two therapies actually function and maybe where they are typically administered.
Well, the physical distinction is the most dramatic. HD is an extracorporeal therapy.
Outside the body.
Exactly. It necessitates the continuous circulation of the patient's blood outside the body, running it through a machine and across a synthetic membrane. That's the dialyzer for filtration.
Okay.
In the inpatient setting, this filtration is almost always performed intermittently, usually, 3 to 4 hours per session, maybe 3 times weekly. It's a high-impact concentrated treatment.
And PD, by contrast, uses the body itself as the filter, which is, well, a key differentiator.
A huge difference. PD uses the patient's own highly vascular peritoneal membrane as the natural filter.
Right, inside the abdomen.
Yes. This requires instilling specialized dialysate fluid into the peritoneal cavity, the belly, to allow clearance to happen internally.
So HD is machine-dependent, often centralized in a unit.
Or requires bringing specialized acute care machines to the bedside, PD, though, is uniquely adaptable. It's usually thought of as a home-based therapy, right? Either continuous ambulatory PD, CAPD, where patients manually exchange fluid during the day.
Okay.
Or automated PD, APD, which uses a cycler machine, often overnight while they sleep.
And this bedside feasibility, even when performed acutely in the hospital, that sounds like a major logistical advantage if the staff is trained.
That's the key caveat, the training. But yes, potentially a big advantage.
So let's look deeper into the physics of how waste is removed. The mechanisms are distinct. HD uses 2 main forces, diffusion and ultrafiltration. Can you elaborate maybe on how diffusion gives us that rapid clearance we associate with HD?
Certainly. Diffusion is entirely driven by concentration gradients. It worked across that semi-permeable synthetic membrane in the dialyzer. So the toxins, things like urea, creatinine, other small molecules, they move rapidly from where they're highly concentrated in the patient's blood to the low concentration in the dialysate fluid.
Just down the gradient.
Exactly. And the synthetic dialyzer membrane is specifically designed for high efficiency, large surface area, which facilitates really rapid removal. This efficiency for small solutes is exactly why HD is the go-to modality for, say, acute toxin clearance.
And ultrafiltration, that's the critical component for fluid removal.
Right.
That operates via hydrostatic pressure, is that right?
That is correct. Ultrafiltration is pressure-driven. Basically, by applying a pressure gradient across the membrane, water is physically forced across it. And it drags some solutes along with it too. That's convection.
Okay.
This allows for extremely precise and, importantly, rapid fluid removal. But, as we'll discuss, that speed comes at a potential cost, especially regarding cardiovascular stability.
So the key point for HD is rapid, high flux, but intermittent clearance. Now, PD's mechanism is entirely different. You said it relies on chemical and osmotic gradients alone, created by the glucose-based dialysate. Walk us through the mechanics of that.
Right. PD clearance is slower, definitely slower per unit time, but it's continuous. The glucose in the dialysate, it's a large osmotic agent.
It pulls water.
Exactly. It draws water, and consequently, the dissolved solutes along with it from the highly vascularized peritoneal capillaries into the peritoneal cavity. Clearance actually happens during the dwell time. That's the period when the fluid just sits in the cavity.
So it's a cycle.
Yes, it's a cycle of filling the cavity, letting it dwell for a prescribed time, and then draining the fluid out. And because this process is continuous over 24 hours, it can remove a similar total amount of solute as intermittent HD, but crucially, without the high peak toxin concentrations or the rapid volume shifts you see with HD.
That continuous, gentler approach. That really sounds like the foundation for modality selection, especially when we think about the frail patient or someone unstable.
It's a key consideration.
Let's transition now to the clinical decision-making, where the urgency of the situation often dictates the choice. The sources seem clear that HD remains the unchallenged default for true urgent intervention.
Oh, that is undeniable. HD is definitely the standard of care for acute kidney injury, AKI, especially when the required intervention is time-sensitive. If you have a patient crashing, HD is the priority. That's assuming, of course, we can establish vascular access quickly.
Which usually means a temporary central line.
Usually, yes. A non-tunneled central venous catheter.
And the speed is essential for those life-threatening metabolic derangements. We're talking about situations with immediate mortality risk.
Absolutely. The need for rapid correction of severe hyperkalemia, let's say potassium over 6.5, with active ECG changes like peaked T waves or a widening QRS complex, that demands the speed of HD.
No time to waste. None. The same goes for severe anion acidosis that isn't responding to bicarbonate treatment or acute uremic complications. Things like uremic encephalopathy causing altered mental status or uremic pericarditis. In these cases, HD's rapid high flux clearance is absolutely necessary to prevent immediate catastrophic outcomes.
And crucially, HD is preferred and definitely superior for removing dialyzable toxins. We've all seen cases, maybe lithium toxicity, ethylene glycol poisoning, or massive salicylate overdoses. PD just can't match that clearance rate, can it?
No, it can't achieve the same rate needed to rescue the patient in those acute poisoning scenarios.
It makes sense. HD is rapid clearance via high blood flow and diffusion across an artificial membrane.
Whereas PD is slow, continuous clearance driven by an osmotic drag across a biological membrane. So when you have a rapidly rising toxin level or a very high toxic level to begin with, PD's inherent slowness is just inadequate.
But the clinical literature seems to forcefully argue against the reflexive use of HD when that extreme urgency isn't the primary factor. PD is also called the gentle alternative, and this seems to be where it carves out its niche, particularly in critical care settings.
Yes, and that's an important point. PD is actually equally effective for most AKI indications when the metabolic derangement isn't immediately life-threatening.
Okay.
Its key advantage, as you mentioned, is hemodynamic stability. This makes PD particularly advantageous for patients with severe cardiovascular instability. Think about patients suffering from acute decompensated heart failure or patients who are dependent on high doses of vasopressors like norepinephrine.
And the reason for that stability is clear. PD avoids those rapid, large volume fluid shifts inherent in intermittent HD.
Exactly. HD might remove, say, 4 liters of fluid in just 4 hours. Even in a relatively healthy patient, that can cause a transient drop in blood pressure. But in a patient already on vasopressors, with maybe borderline cardiac output, that rapid fluid removal can induce severe intradialytic hypotension. That can precipitate further organ injury or even myocardial stunning.
Whereas PD performs continuous ultrafiltration over 24 hours, avoiding that shock.
Precisely. And if a Tenkov catheter, the PD catheter, is already in place, and we're seeing more discussion around urgent start PD protocols, it offers a continuous, bedside, less disruptive option that minimizes systemic stress.
That seems like a huge potential benefit in the ICU.
It can be.
Now, we must address the clear no-go situations, the absolute contraindications for each modality. Let's start with PD. What are the definitive barriers that prevent a patient from using their peritoneal membrane?
Well, for PD, the cavity itself must be viable, accessible. So absolute contraindications would include extensive, complex intra-abdominal adhesions, maybe from multiple prior abdominal surgeries. These will prevent the dialysate from circulating effectively.
The fluid can't get where it needs to go.
Right. Similarly, recent major abdominal surgery or the presence of something like a massive ventral hernia can compromise the integrity of the peritoneal cavity or complicate the safe placement and function of the catheter.
And the ability to safely perform the exchanges is also a barrier, isn't it? If the patient can't physically do the exchange and there's no trained caregiver available.
That becomes a critical operational barrier, yes. Patients with severe cognitive impairments or perhaps profound physical limitations, they must have reliable, certified caregiver support. Without it, the risk of contamination during exchanges and subsequent peritonitis becomes unacceptably high.
Okay. Conversely, what's the main absolute contraindication for HD?
Really, the main one is the inability to obtain suitable vascular access. While most centers can place a temporary central venous catheter, in very rare instances, maybe due to superior vena cava syndrome, extensive central venous thrombosis, or complex anatomical variations, it might actually be impossible to initiate HD safely.
So in those very rare scenarios, if the patient is stable enough otherwise, PD might become the only viable option.
It potentially could be, yes.
And we also often select PD in cases where HD is merely relatively contraindicated, but still carries a high risk. You mentioned hemodynamic instability.
Yes, severe hemodynamic instability, which we've discussed. Another big one is active, uncontrolled bleeding.
Why is that?
Because PD does not require routine circuit anticoagulation, unlike HD, which almost always does. So PD drastically lowers the systemic bleeding risk associated with the procedure itself. It becomes the clear choice for a patient who needs RRT but has, say, a recent cerebral hemorrhage or an acute gastrointestinal bleed.
That's a major safety advantage.
It is. And of course, things like severe cardiac arrhythmias or unstable angina, which can be exacerbated by the volume shifts of potential pressure drops of intermittent HD, those are also strong relative contraindications where PD's gentleness is often preferred.
Okay, moving from clinical selection to the reality of the hospital setting. We have to look at access types and the logistical gauntlet hospital staff often face. The access for these two modalities is entirely different. Completely different. For acute HD, the necessary access is usually the non-tunneled, non-cuffed double lumen catheter. These are inserted relatively quickly, typically into the right internal jugular vein if possible. They need to allow high enough blood flow rates, often 300 to 450 milliliters per minute, to support effective dialysis.
So speed is the benefit, but risk is the cost here. These temporary catheters are notorious hotbeds for catheter-related bloodstream infections, CLABSI, and they carry a high risk of thrombosis if left in place too long.
Absolutely. They are a major source of hospital-acquired infections. For chronic HD, the goal is different. The arteriovenous fistula, or AVF, created surgically by joining an artery and vein directly, is the gold standard.
Lower infection risk.
Much lower infection and complication risk overall. But the big drawback is they require months to mature before they can be used reliably.
So what do patients use in the meantime?
Well, an alternative is the arteriovenous graft, or AVG. This connects an artery and vein using a piece of synthetic material. It matures faster than a fistula, maybe in weeks, but it has a higher infectious and thrombosis risk than the patient's own tissue AVF. And then there are tunneled central venous catheters, which serve as intermediate or sometimes long-term bridge access when AV access is pending maturation, or if it's impossible to create.
Okay. Peritoneal access, on the other hand, relies solely on the Tenkoff catheter.
That's right. This is a soft silicone catheter that's surgically or sometimes radiologically placed through the anterior abdominal wall into the peritoneal cavity.
And it's designed differently than the HD catheters.
Yes, the Tenkoff is designed for more permanence and lower infection risk compared to CVCs. It's anchored subcutaneously under the skin by one or usually two Dacron cuffs.
What do the cuffs do?
They serve two critical functions. First, they help fix the catheter in position to prevent migration. Second, and very importantly, they induce tissue ingrowth, which acts as a physical barrier to microbial migration along the tunnel tract from the skin exit site into the peritoneum, minimizing the risk of tunnel infections and peritonitis.
Makes sense. Now let's confront the workflow challenges, because this is where the clinical ideal often meets institutional reality. HD requires a specialized ecosystem within the hospital.
It really does. HD demands dedicated, highly trained nursing staff, complex equipment, the dialysis machines themselves, the water treatment systems, the dialysate mixing systems, and often it requires transporting the patient to a centralized dialysis unit.
Which can be disruptive for sick patients.
Very disruptive. Even if the machine is brought to the ICU bedside for continuous therapy like CRRT or sometimes intermittent HD, the procedure still requires specialized staff and takes fixed, lengthy treatment times. This requirement pulls specialized nursing resources, disrupts the critically ill patient's routine care schedule, and introduces risks during transport if that's needed.
It's fascinating how rigid the hospital culture often remains around this. Despite the known benefits of gentler therapy like PD for cardiovascular stability, the sheer availability and familiarity of HD staff and machines often means HD becomes the path of least resistance.
PD seems to face significant institutional inertia.
That's precisely the key challenge. Often it's the scarcity of staff expertise with PD. In many U.S. hospitals, general floor nurses and even many ICU nurses are simply not trained or credentialed in performing PD exchanges or managing the therapy acutely.
Because it's seen mainly as outpatient.
Exactly. Because PD is viewed predominantly as an outpatient home-based therapy, many hospitals lack established, readily available, urgent start PD protocols, even though evidence shows PD can be initiated safely and effectively in the acute setting.
So overcoming those staff training barriers seems like the single biggest step needed.
I believe it is. It's key to expanding the use of PD in acute care. If we could do that, we could offer bedside treatment that is potentially less disruptive, less resource-intensive in terms of machinery, and more flexible than intermittent HD for many patients.
It feels like we might be letting logistics and historic default protocols drive potentially suboptimal care for vulnerable patients who could benefit from that gentler approach PD offers.
That's a valid concern and something institutions need to grapple with.
Okay, let's delve deeply now into managing clinical complications and risks. These are significant for both modalities, but they manifest in profoundly different ways, starting with the hemodynamic and metabolic effects.
Right. HD is almost synonymous with a high risk for hemodynamic instability. We see intradialytic hypotension, or IDH, occurring in a really staggering number of sessions, somewhere between 4% and maybe up to 17%, or even higher in some studies.
And this isn't just a simple transient drop in blood pressure, is it?
No, it's often accompanied by significant symptoms like muscle cramps, nausea, vomiting, and profound post-dialysis fatigue or washout.
And the core physiological concern here seems to be the rapid ultrafiltration rate, pulling fluid off that quickly.
Exactly. When you pull fluid that rapidly, you can temporarily reduce the circulating plasma volume faster than the body can refill that vascular space from the interstitium. This mismatch leads to hypovolemia and hypotension, which in turn can cause transient tissue ischemia.
And the most concerning consequence of that ischemia is myocardial stunning.
That's right. The heart muscle itself, deprived of adequate perfusion during the hypotensive episode, suffers this reversible ischemia, this stunning. And the concern is that repeated episodes of myocardial stunning, session after session, year after year, are believed to contribute significantly to the very high cardiovascular morbidity and mortality associated with long-term HD.
Does it affect other organs too?
Yes. There's also evidence it contributes to cerebral hypoperfusion and possibly the stunned kidney phenomenon in AKI patients, where repeated ischemic insults might actually delay or prevent renal recovery.
Now, in stark contrast, you've mentioned PD's continuous gradual fluid removal minimizes hypotension.
It does. It markedly improves hemodynamic stability compared to intermittent HD. So for patients with severe heart failure, where aggressive fluid management is absolutely paramount but rapid drops in blood pressure could be deadly, PD often offers a far safer, gentler strategy for fluid removal.
Metabolically, both correct uremia, but the method differs significantly in its effect.
Yes. HD provides rapid, high-magnitude correction of electrolytes and acid-base status. That's good, as we said, for severe hyperkalemia or severe acidosis. But these abrupt shifts can sometimes trigger problems like dialysis, disequilibrium syndrome, especially if initiated too aggressively, or they can compound underlying hemodynamic instability.
And PD.
PD offers smooth, continuous metabolic control, less dramatic shifts.
A critical metabolic difference seems to revolve around potassium and glucose.
Yeah.
HD patients typically require strict dietary potassium restriction, right? Often less than 3 grams per day.
That's generally true, yes. Because the intermittent nature of the therapy means potassium accumulates significantly between dialysis sessions. The diet has to compensate for that lack of continuous removal.
But PD patients are different.
Completely different, usually. PD patients are actually often prone to hypokalemia.
Low potassium. Why?
Because the continuous nature of the clearance, coupled with the typical potassium gradient between blood and standard dialysate, which is often potassium-free, can lead to excessive potassium removal over time. They frequently require potassium supplementation, either orally or added to the dialysate bags.
That's counterintuitive.
Yeah.
And the other major metabolic caveat for PD is the glucose absorption from the dialysate.
Yes, this is a major long-term consideration. The glucose acts as a necessary osmotic agent, but also provides a significant calorie source, which can be protein-sparing to some extent. However, this constant, unavoidable glucose absorption poses a significant risk of hyperglycemia, worsening glycemic control in diabetics, and contributing to the development of metabolic syndrome, hypertriglyceridemia, and unwanted weight gain over the long term.
So it demands really vigilant blood glucose monitoring, mandatory, especially for diabetic patients.
Absolutely mandatory.
Okay, shifting gears to infection risks. These are, you mentioned, a leading cause of hospitalization, yet the site and the likely organism differ completely between the two modalities.
Very different profiles. For HD, the entire infectious risk profile is centered on the vascular access. The primary threat is catheter-related bloodstream infection, CLABSI, particularly with those temporary central venous catheters used for acute HD.
And the rates are high.
Alarmingly high. Published rates range from 1.1 up to maybe 5.5 episodes per 1,000 catheter days. That risk is definitely highest with the non-tunneled acute access lines and is compounded by the duration of the hospital stay and catheter dwell time.
Those numbers represent a massive infection burden that, frankly, clinicians often just seem to accept as part of the HD equation.
It's a significant challenge. Prevention protocols like strict sterile insertion bundles, using chlorhexidine, skin prep, meticulous hub care and manipulation are absolutely essential, but often difficult to enforce perfectly consistently in a busy acute care setting.
Okay, so that's HD. What about PD?
For PD, the primary infectious concern is peritonitis. That's inflammation and infection within the peritoneal cavity itself.
How common is that?
The incidence is generally lower than the CLABSI rates seen with HD CVCs. It sits around 0.26 to 0.30 episodes per patient year on average in well-managed programs. However, peritonitis is a very severe event when it occurs. It almost always requires hospitalization.
And can lead to losing the PD access.
Yes. Frequently, it requires temporary or sometimes permanent catheter removal, which is a significant setback and loss of modality for the patient. Exit site and tunnel infections along the catheter track are also common, but usually less severe than peritonitis.
Clinically, how does peritonitis typically present? You mentioned cloudy fluid.
Yes, cloudy dialysate effluent is the most specific sign. It's often accompanied by abdominal pain, sometimes fever or nausea. This presentation demands immediate attention.
And the workup.
The clinical response needs to be swift. We immediately obtain a sample of the effluent fluid for cell count with differential, Gram stain, and culture. A white blood cell count in the effluent over 100 cells per cubic millimeter with more than 50% neutrophils is diagnostic for peritonitis.
And treatment starts right away.
Immediately. Empirical broad-spectrum antibiotics that cover common gram-positive and gram-negative organisms are initiated right away, typically given directly into the peritoneal dialysate fluid intraperitoneally. Common choices might include an internal dose of cefepime plus vancomycin, or perhaps an aminoglycoside like gentamicin, but therapy should always be tailored to local resistance patterns and later adjusted based on culture results.
So putting it together, while PD patients might have higher overall hospitalization rates reported in some studies, those seem largely driven by this infection risk, specifically peritonitis and its related sequelae.
That's often the case, whereas HD hospitalizations tend to be driven more by cardiovascular events, perhaps related to those repeated hemodynamic stresses, and also by vascular access complications like CLABSI, thrombosis, or access failure requiring intervention.
Okay. Finally, under complications, anticoagulation. This sounds like a definitive line in the sand between the two modalities.
It really is. HD inherently requires routine anticoagulation. To prevent the patient's blood from clotting as it passes through the extracorporeal circuit, the lines in the dialyzer, unfractionated heparin given as a bolus and then often an infusion during the treatment is the standard approach. But this, of course, introduces systemic bleeding risk into every single HD session.
Which necessitates careful risk stratification, especially in hospitalized patients who might already be bleeding or postoperative.
Absolutely. For patients at extremely high bleeding risk, say immediately post-op, or someone with active internal bleeding, or severe thrombocytopenia, we absolutely must seek alternatives to systemic heparin.
What are the main alternatives?
Well, one option is heparin-free dialysis, which relies on frequent high-volume saline flushes through the circuit to try and prevent clotting. It's less reliable and can shorten dialyzer life. A more sophisticated method is regional citrate anticoagulation.
How does citrate work?
Citrate works locally only within the extracorporeal circuit. It chelates calcium, and calcium is essential for the clotting cascade. So, by binding calcium, citrate effectively anticoagulates the blood in the circuit. Then, calcium is infused back into the bloodline just before the blood returns to the patient to reverse the effect and restore normal systemic coagulation.
Sounds complex.
It is more complex, requires careful monitoring of calcium and electrolytes, but it's a much safer option for patients with high bleeding risk undergoing HD or continuous therapies like CRRT.
And PD avoids all this complexity.
Completely. There is no routine circuit anticoagulation needed because the blood never leaves the body. Systemic anticoagulation in PD patients is only necessary if they have other pre-existing comorbidities that require it, like atrial fibrillation or VTE.
That's a significant advantage in many inpatient scenarios.
It can be. And it's noteworthy that even for end-stage kidney disease patients, both HD and PD, who do require oral anticoagulation for something like AFib, the direct oral anticoagulants, the DOACs, like apixaban, are often preferred nowadays over vitamin K antagonists, like warfarin.
Why is that?
Generally due to evidence suggesting a lower overall bleeding risk profile, especially major bleeding like GI bleeds, compared to VKAs in the ESKD population. However, the exact dosing of DOACs requires very careful adjustment based on residual renal function and dialysis modality, and frankly, the overall net clinical benefit of anticoagulation versus bleeding risk in this specific high-risk population remains an area of ongoing research and very individualized decision-making.
Right. Always complex in kidney disease.
Yeah.
Let's pivot now to two other clinical pillars of inpatient management: nutritional status and volume control. These seem like markedly different challenges depending on whether the patient is receiving intermittent HD or continuous PD.
They really are different challenges. First, both HD and PD patients are highly susceptible to protein energy wasting, or PUW. It's a common and serious problem. Their recommended protein intake is exceptionally high to counteract this, typically in the range of 1.0 to 1.2 grams per kilogram of ideal body weight per day.
Why so high?
It's multifactorial. Uremia itself induces a catabolic state, there's inflammation, poor appetite is common, plus the dialysis process itself causes loss of amino acids and peptides.
But PD patients seem to face a unique challenge with constant protein loss. Can you quantify that loss, and why does it happen specifically in PD?
Yes, the continuous nature of PD means the peritoneal membrane acts as a constant low-grade filter for proteins as well as toxins. This leads to significant daily protein loss, specifically around 6 to 8 grams per day on average, primarily albumin and also immunoglobulins, lost directly into the drained dialysate effluent.
6 to 8 grams every day.
Every day. This continuous loss necessitates incredibly close nutritional monitoring, regular assessment of albumin levels, and potentially aggressive nutritional supplementation, sometimes even intraperitoneal amino acid solutions, to prevent progressive malnutrition, which is linked to poor outcomes.
And we come back to the glucose issue in PD. The glucose load in the dialysate provides calories, which you said is protein-sparing to some extent.
It does provide calories, yes, which can help offset some catabolism.
But this constant high-dose delivery of glucose leads to that unavoidable absorption. This seems to be the root cause of the long-term metabolic risks: new-onset diabetes, worsening metabolic syndrome, significant weight gain in many PD patients over time.
That's correct. It requires a dedicated endocrinological approach, often running parallel to the nephrology management, focused on diet, exercise where possible, and potentially adjusting diabetic medications.
Okay. Now regarding volume control, HD offers what seems like a straightforward solution: precise, rapid, pressure-driven ultrafiltration by the machine.
On the surface, yes. Managing hypertension and achieving euvolemia, or dry weight, in HD patients relies heavily on the clinician accurately calculating and prescribing the ultrafiltration goal for each session, and then adjusting the patient's target dry weight based on clinical assessment. Success also depends heavily on the patient adhering to strict sodium and fluid restrictions between sessions.
But the challenge is always balancing that need for aggressive fluid removal with the risk of causing that intradialytic hypotension, the IDH we talked about.
Exactly. It's a constant tightrope walk in HG.
PD, on the other hand, offers a slower yet also effective mechanism for volume control. It relies entirely on that osmotic gradient created by the glucose in the dialysate, right?
Correct. Hypertension is actually highly prevalent in PD patients too, affecting maybe up to 80 or 90% in some series. But it's managed not by rapid machine adjustments during a session, but primarily by titrating the concentration or conicity of the glucose in the dialysate bags used for exchanges.
Higher glucose pulls more fluid.
Yes. Using dialysate solutions with higher glucose concentrations creates a stronger osmotic gradient, pulling more water, ultrafiltrate, from the patient into the peritoneal cavity continuously throughout the dwell time. Patients often use a mix of different glucose strengths during the day or night to achieve their fluid balance goals, along with dietary sodium and fluid restriction, of course.
The gentleness seems paramount here again. PD allows for continuous monitoring and adjustment of fluid removal without the abrupt physiological shock of pulling off liters in just a few hours.
Right. This makes it an excellent tool for managing refractory hypertension or chronic volume overload, especially in complex patients like those with severe heart failure where you want slow, steady fluid removal.
Finally, let's touch on the specific monitoring demands during therapy. These seem to reflect the unique risks of each modality. What are the key points of focus for each?
For HD patients, particularly those in the acute setting, like with severe electrolyte abnormalities or AKI, or those with underlying cardiac disease, continuous ECG monitoring during the treatment is often mandated.
Why ECG?
To detect potentially fatal arrhythmias that can be precipitated by the rapid potassium shifts or large fluid shifts occurring during HD. Vigilance for signs and symptoms of intradialytic hypotension, dizziness, cramping, nausea, and close monitoring of the vascular access for any issues like bleeding or clotting are continuous throughout the session. Blood pressure monitoring is obviously frequent and critical.
Okay. And for PD, the monitoring shifts entirely to the patient's abdomen and the effluent fluid.
Largely, yes. The number one priority for nurses and patients managing PD is vigilant monitoring for the signs and symptoms of peritonitis, cloudy, effluent, and abdominal pain being the cardinal red flags.
What else?
Additionally, close observation of volume status, weight changes, edema, blood pressure, ensuring adequate ultrafiltration by measuring fluid balance, and, as we stressed, meticulous blood glucose monitoring in diabetic patients is mandatory due to that dialysate glucose load. Exit site care and monitoring for infection are also crucial daily tasks.
And you mentioned something about bowel function earlier.
Yes, we must not forget the importance of bowel function in PD patients. Catheter function can be severely compromised by constipation.
How so?
A distended bowel full of stool can physically impinge upon or block the PD catheter tip within the peritoneal cavity, preventing adequate drainage of the dialysate. This leads to incomplete exchanges and inadequate dialysis. Ensuring regular bowel movements, often through the proactive use of osmotic laxatives, is a simple yet absolutely critical piece of routine PD management that directly impacts the efficacy of the treatment.
Good point. Okay, our final topic aims to synthesize the long-term data. Let's look at comparative outcomes and prognosis. Does one modality ultimately offer a clear survival edge?
You know, what's fascinating about the large body of long-term observational and registry data is that after researchers perform extensive statistical adjustments to account for the many differences in baseline patient characteristics, things like age, the presence and severity of diabetes, cardiovascular disease burden, the general consensus suggests that long-term mortality rates for HD and PD are essentially modality neutral.
So similar survival overall.
For the average patient population, once you account for those confounding factors, yes. They seem functionally similar in terms of long-term survival.
However, those adjustments are crucial. And the literature does suggest some specific nuances, doesn't it? Some studies indicate PD might offer an early survival advantage.
That's true. There is some evidence, particularly from earlier eras of dialysis, suggesting that PD may offer an early survival advantage, typically within the first 1 to 2 years after starting dialysis. This seems most pronounced for younger patients, those who are non-diabetic, and those who lack significant baseline cardiovascular disease.
What's the hypothesis behind that early advantage?
Well, it's hypothesized to be related perhaps to PD, avoiding the immediate risks associated with creating and using vascular access, especially central venous catheters initially. Also, potentially, it relates to avoiding the cumulative hemodynamic damage, like myocardial stunning, that might begin early in the course of HD therapy. Over time, though, this advantage seems to diminish as other factors come into play.
We also see the role of assisted PD expanding, especially for frail patients.
Yes, this is an important option. For the frail or elderly patient, where regular transport to an in-center HD unit 3 times a week can be physically debilitating and socially isolating, assisted PD, where a trained family member or a home health nurse manages the exchanges, is proving to be a very feasible alternative.
And outcomes are comparable.
Studies suggest it offers similar hospitalization rates to in-center HD in this population, but often with significant improvements in patient-reported quality of life, which is a major outcome consideration, especially for palliative-focused care.
When summarizing the main drivers of hospitalization, the patterns seem clear and really tell the story of the modality's inherent risks.
They do. Hospitalization rates remain high for both groups, unfortunately, but the primary reasons differ. As we discussed, HD patients tend to be hospitalized primarily for cardiovascular events. Heart failure, myocardial infarction, stroke, often seen as sequelae of repeated hemodynamic stress and underlying disease, and also frequently for vascular access complications like infections or thrombosis requiring procedures.
Whereas PD patients,
PD patients are hospitalized predominantly due to peritonitis and its related treatment sequelae, like catheter removal or temporary transfer to HD.
therefore, the final choice for renal replacement therapy, especially initiating it in the hospital, must be highly individualized. We need to move away from just institutional defaults.
Absolutely. We default to HD for those true emergencies requiring extreme urgency and rapid correction of life-threatening imbalances.
Right.
But PD is often physiologically superior, the gentler option, for the patient with severe cardiovascular instability or high bleeding risk, provided the infrastructure allows it.
And many other factors play a role.
Of course. The overall clinical scenario, the patient's own preferences and lifestyle goals, their social support structure, their ability to manage the therapy or have assistance, and crucially, their residual renal function all play a significant role. PD is generally considered better at preserving residual renal function for longer compared to HD, and preserving that residual function is a known predictor of better quality of life and even survival.
And importantly, we should probably challenge the traditional assumption that almost all perioperative patients must automatically switch from PD to HD, shouldn't we?
Yes, that's often an outdated practice. With appropriate planning, careful surgical technique, and sometimes temporary adjustments to the PD prescription, PD can often be safely resumed relatively soon after many types of abdominal and non-abdominal surgery, avoiding the disruption and risks of placing temporary HD access.
This deep dive has really, I think, effectively reviewed the nuanced evidence contrasting these two essential modalities. While HD must remain the default for acute, life-threatening emergencies because of its sheer speed and near-universal availability in hospitals,
It has to be.
we've clearly established that PD's inherent hemodynamic gentleness is often superior, physiologically, for the critically ill or unstable patient, provided, and this is the big caveat, that the hospital environment can actually support the infrastructure and the staff expertise required.
That infrastructure gap, that discrepancy, really raises the most important question for hospital medicine moving forward, doesn't it? Given that PD offers superior hemodynamic stability, given that it avoids the significant and life-threatening risks associated with central vascular access needed for acute HD, and given that robust observational studies show similar long-term mortality, with even potential signals for superior cardiovascular outcomes in select patient groups, why do we still tolerate a system where hospital infrastructure does not consistently support readily available urgent start PD protocols?
It's a powerful question.
This persistent disparity between the clinical evidence favoring PD in certain acute situations and the common institutional capability or willingness to provide it,
Right.
well, that represents perhaps the most significant, immediate opportunity for practice improvement in the care of our most vulnerable hospitalized patients needing renal replacement therapy. It's something we really need to address systemically.